At the onset, I would like to thank the organizers of MAC 2021 for giving me this opportunity to speak on this interesting topic of clinical pearls in nephrology, lupus nephritis. So we start off with a clinical case. Now, this is a 39-year-old female from Mizoram. She's a housewife. She has 2 living issues with no obstetric complications, who presented with history of arthralgias for 8 months, which was involving both the upper and lower joints, small as well as large joints, symmetrical, with morning stiffness and no residual deformities. She had history of ulcerations, oral ulcerations, hair loss, some skin lesions on the back and face with history of photosensitivity. She had on and off history of fever for last 3 months and anasarca for 1 month. Now, she was hypertensive on examination. She had hyperpigmented macules in the back and malar region, thyroid gland enlargement, a few subcentrometric neck nodes were palpable. Pitting pedal edema was there, and systemic examination was normal. Now, her labs showed an anemia with normal WBC and platelet counts. She had a mild renal dysfunction with microhematuria, a nephrotic range proteinuria with hypoalbuminemia. She had a subclinical hypothyroidism with positive anti-TPO and anti-thyroglobulin antibodies. Her serological test showed positive ANA, which was homogeneous with significantly increased DNA. Her Rho and La antibodies were positive. Her complements were low. DCT was positive and EPLA workup was negative. On imaging, her ultrasound was normal. Now, she had a SLICC criteria of 9/17 with a SLEDI score of 32. Now, we went ahead with a renal biopsy, and what her renal biopsy showed was a class 4 lupus nephritis, wherein you can see the entire glomeruli. There is an endocapillary proliferation and there is a crescent over here. So one glom showed a crescent. Activity was significant, 12/24, and chronicity score was 0/12. Immunofluorescence showed a full house pattern. So she received induction therapy with IV methylprednisolone, followed by deflazacort 60 mg once daily, and she was started on a IV cyclophosphamide NIH regimen with HCQs, ACE inhibitors. So this was in December 2014 when she presented to in the Department of Medicine. A biopsy was done and she was started on her induction therapy with NIH cyclophosphamide. Now, 3 months down the line, she had her partial remission of proteinuria, her creatinine normalized, her serological markers also improved. After 6 months of IV cyclophosphamide, she was in complete remission with proteinuria of 800 mg with normal creatinine, normal serological profile, and her SLEDI score also decreased to 14. She complained of amenuria, which was probably due to cyclophosphamide. So at this point, her steroid was started to be tapered, and she was on, by the time, by 6 months, she was on a low dose deflazacort, and she was started on a maintenance therapy with mycophenolate, which was started at 1 gram twice daily. 1 year down the line, again, she is normal. All her labs are normal, serologically normal. She had now Cushingoid features, and that deflazacort was stopped at this point of time. 2 years down the line from the initiation of maintenance therapy, that is in April 2017, she had again normal labs. Her creatinine was normal. Serologically, she was inactive. Her MMF at this point, after 2 years, was planned to be tapered and stopped over the next 3 months. So 2 years down the line from initiation of MMF, it was stopped. Now coming to in November 2019, that is 2 years after stopping the immunosuppression, she now presented with a relapse. And this was both a mucocutaneous relapse as well as a renal relapse. Her creatinine increased to 4.2. She had nephrotic range proteinuria with hypoalbuminemia, very active serological profile. So at this point, a biopsy was done, which again showed class 4 lupus nephritis, but now there was cellular crescents in almost 42% of glomeruli. She was given a IV methylprednisolone followed by deflazacort, and she was started on a induction therapy with MMF. Now, in Feb 2023, 3 months after starting this induction therapy, she presented with history of general tonic-clonic seizures, NSRK, and decreased urine output, and she was referred to Department of Nephrology. Now, when we looked at her, we found that there was no improvement in her creatinine in spite of the induction therapy. A workup for her seizure showed a normal MRI brain. Electrolytes and calciums were normal. She had a nephrotic range proteinuria, active urine sediments, hypoalbuminemia. Serologically, she was still active. What we observed was she had a bicytopenia. She had a anemia plus low platelet count, and she had features of TMA with a high retic count, cystocytes significantly increased, high LDH. Her Adams 13 activity was normal, and APLA workup was found to be normal. So what we did was we continued the prednisolone and mycophenolate, gave her 5 sessions of plasma pheresis, and she also required 2 sessions of dialysis and 6 sessions of ultrafiltration. And she was given a dose of rituximab, 1 gram of rituximab. With this, there was an improvement in her hematological parameters, but her creatinine still remained at 4.5. A renal biopsy, once a platelet improved, was done. And now what her renal biopsy showed was again a class 4 lupus nephritis, but with significantly increased chronicity scores. And there was presence of TMA on the biopsy. By September 2020, she became dialysis dependent at her local place. She was initiated on maintenance hemodialysis 2/7, and a right brachiocephalic fistula was created. Last month, she came to us back, and she's being worked up for renal transplant with sister as a prospective donor. Her serologically, she is inactive now. So this particular case gives us multiple areas of discussion. So we will go to one or to each of these areas in as far as clinical parameters are concerned. Now, lupus nephritis is seen in almost half of patients with SLE, usually presents in the early part of the disease. And the risk factors are males, young age, Asians, Blacks, and Hispanics, and certain autoantibodies like Smith, Rowe, and RNP antibodies. Now, how do you diagnose SLE? Now, the renal involvement in SLE involves almost all patients will have proteinuria, with half of them having nephrotic syndrome. 80% of patients with lupus nephritis will have microhematuria, whereas gross hematuria is much less common. In spite of all therapies, 15% of patients progress to end-stage kidney disease. Now, what are the risk factors for progression to end-stage kidney disease? Again, males, pediatric onset, Blacks and Hispanics. At presentation, if you have a nephrotic range proteinuria, if there is a delay in biopsy and treatment of induction therapy, in spite of therapy, if there is an incomplete remission, or when there are frequent relapses. At our center, we found 4 important factors which are likely to progress to ESKD, that is hypertension, class 4 histology, eGFR at presentation less than 75, and serum albumin less than 3.5 gram per deciliter. Now, coming to how do you estimate proteinuria? Now, one simple way is to do a dipstick test, which is based on a tetrabromo-phenol blue indicator. So, in presence of acidic urine, if there is no proteinuria, you'll get a yellow color on dipstick, and it becomes green in color if with the degree of proteinuria. So, based on the shade of green, we can quantify this, semi-quantitatively quantify the proteinuria and grade it into trace 1+ to 4+. But the gold standard for estimation of proteinuria is a 24-hour urine collection. Now, very important whenever you send a 24-hour urine collection is to look for 24-hour urine creatinine. That is to assess the adequacy of the sample. So the 24-hour urine creatinine in a female should be at least 10 mg per kg, and a male it should be at least 15 mg per kg. The other way of doing it is to do a urine protein creatinine ratio on a first voided urine sample, not on a spot urine sample. This is another way of estimating proteinuria. Now, this is preferred when you're doing a routine follow-up, but when for an initial diagnosis and when a change of therapy is planned, it is better to do a 24-hour urine protein. Now, glomerular hematuria means presence of at least one RBC cast. RBC casts are nothing but RBCs with TAM, Housefall protein, or uromodulin. Presence of dysmorphic RBCs more than 40%. Dysmorphic RBCs means RBCs of different shapes and sizes. and presence of acanthocytes. Like this insert shows an acanthocyte, it's a ring-like structure with multiple blebs on the surface. Now, is microhematuria in SLE always active? No. Always in females, rule out if patient is menstruating, and always keep in mind the possibility of hemorrhagic cystitis due to cyclophosphamide. Now, when do we biopsy a patient with lupus? So which are the conditions wherein you have to refer a patient to nephrologist for a biopsy? One, if there is proteinuria more than 500 mg per day with or without active urine sediments. There is presence of renal dysfunction, which is not attributable to any cause. The other two indications are, one is SLE with a very active serology, but there is no clinical renal involvement in the form of renal dysfunction or significant proteinuria. Now, this is done to rule out something called as silent lupus nephritis. And the fourth entity, when we biopsy a lot of medicine patients, is when there's a diagnostic uncertainty. Now, we know there is a the SLICC criteria has to be met for making a diagnosis of SLE. So when it is not met at at a point of time to help in diagnosis, that will we do a renal biopsy. Microhematuria per se without proteinuria is not an indication for renal biopsy. So as I said, SLICC criteria involves for diagnosis at least 4 out of 17 criteria. One should be a clinical and one should be a immunological criteria. So when it's not meeting a SLICC criteria at a particular point of time, and we know that symptoms of SLE is longitudinal. It takes over a period of time when different organs get involved. So when diagnosis query is a problem, then we know that there is a option in SLICC criteria which states that if there is a biopsy proven LN with positive ANA, then you can make a diagnosis of SLE. Now, when do you do a repeat renal biopsy? Like in a patient, we did biopsy 2 times. So the first thing is when you have a lupus flare. So the first thing the patient after stopping MMF after 2 years, she had a flare. So when lupus flare, you do a biopsy to look for class switching. And then second thing is when you have a resistant lupus nephritis. So in our case, in spite of MMF induction, 3 months down the line, patient didn't improve. We did a rebiopsy. Why do we do the rebiopsy? To look for whether there is any features of chronicity or if there is any features of alternative diagnosis like a TMA. Now, the other interesting situation is when a patient of lupus is following up after induction maintenance therapy and patient has a persistently rising proteinuria. Now, we want to know whether this is an active disease or it's a chronic disease. So clinically, if it's a sudden onset large proteinuria like a nephrotic range proteinuria, it is usually a flare. And at the same time, if there's a change in serology from normal to abnormal, it's usually a flare. But it's only a renal biopsy which can actually differentiate a flare from a chronicity, because we have certain parameters called as NIH activity and chronicity scores. Now, what do we do on a renal biopsy? In a renal biopsy, we classify lupus nephritis into 6 classes. Now, when you do a biopsy, there are 3 parts to a biopsy. There is a light microscopy, there is immunofluorescence, and there is a electron microscopy. So, what do we see in a light microscopy? Here, what you can see is a glomeruli. This is the Bowman's capsule. This is the Bowman's space. And normally, if you look, the glomeruli capillaries, you can see the openings. These are called as capillary lumens. And in between the capillary lumens, there's a small pink area that is called as mesengium. So mesengium holds the capillary lumens together. So in minimal mesangial lupus nephritis, you get a normal glomeruli on LM, and on IF and EM, you get immune deposits. In class 2, that is mesangial proliferative, what happens is in between the lumens, the pink mesangial area shows hypercellularity, more than 3 cells. You can see here there are some 6 to 7 cells. And also there will be expansion of this mesangial matrix expansion, MME. So this is seen in mesangial proliferative lupus nephritis. Now in class 3 and class 4, what you get is something called as endocapillary hypercellularity. So what happens is here in this B and C, you cannot see the lumen. All the capillary lumens are filled. So that is called as endocapillary hypercellularity. When you have this endocapillary proliferation in more than 50% of glomeruli, you call it as diffuse, or else you call it as focal. Now in class 5 or membranous nephropathy, what you get is there's a thickening of the glomerular capillary walls. If you look over here, this is the glomerular capillary wall. You can see the wall is thickened as compared to a tubular basement membrane. And in class 6, you have chronic sclerosing lesion. This pink thing, what you see is a sclerosing lesions. Now, why do we classify this? What is the clinical implication of this ISN RPS classification? Now, based on the ISN RPS classification, we can divide the patients into proliferative and non-proliferative lesions. Proliferative lesions are class 3 and class 4, and non-proliferative lesions are class 1, 2, 5, and 6. Besides these two, we also know there are other lesions which can come, like TMA, which was seen in the third biopsy in our case. And also you can get an entity called as lupus podocytopathy. Now, this is for the purpose of deciding whether we need to give immunosuppression or not. So immunosuppression is indicated in all patients with class 3, class 4 lupus nephritis, and in patients with class 5 lupus nephritis with that is membranous nephropathy with a nephrotic range proteinuria. Also, if you look, there is also a clinico-pathological correlation you can see in this ISN classification. You can see this hypertension is more common as you come down. Proteinuria in the nephrotic range is mainly seen in class 4 and class 5. Microhematuria is usually not seen in class 1 and class 6. Renal dysfunction is common in proliferative and sclerotic lesions, and serological markers are more commonly seen in your proliferative lesions. Now, what is silent lupus nephritis? So when you have a lupus nephritis other than class 1 in a patient without any clinical kidney involvement in the form of proteinuria or renal dysfunction is called as silent lupus nephritis. So the incidence is as high as 60%. But what we are really worried is silent lupus nephritis with proliferative lesions and membranous lesions, wherein ideally we need to treat and we might miss out these lesions. So that come up to almost 25% of silent lupus nephritis. So what does it mean? Should we biopsy all cases of SLE? No. So there are certain predictors of silent lupus nephritis in patients without renal involvement. So one is a high dsDNA titer and a low C3 level. So these are the indications for doing a kidney biopsy. And what is the progression to lupus nephritis? Almost a quarter of patients of silent lupus nephritis can progress over a period of follow-up time to frank lupus nephritis. On immunofluorescence, what do you get? You get something called as full house pattern, wherein you get all immune deposits, IgG, IgM, IgA, C1q, and C3. So this is a full house pattern. Is full house pattern specific to SLE? No. It can be seen in HIV immune complex disease and a rare disease called as collagen 3 glomerulopathy. Electron microscopy is not usually done in SLE because we can make a diagnosis with LM and IF. But on electron microscopy, what you get is subendothelial deposits. So if you look over here, this is the glomerular basement membrane. This is your endothelium, and these are the podocytes. So in class 3 and class 4, proliferative lupus nephritis, you get subendothelial deposits. And in class 5, membranous nephropathy, what you get is subepithelial deposits. The other thing what you can find is something called as tubular reticular inclusions. So tubular reticular inclusions are nothing but within the glomerular cytoplasm of the glomerular endothelium, within the endoplasmic reticulum, you can see some interanestomotic tubules. And this is a marker of high interferon. So it's called as interferon footprints. It's also seen in HIV nephropathy. The other thing what you can get on EM is a fingerprinting, wherein you can see a microtubular kind of a structure within the glomerular endothelium, which is also seen in cryoglobinemia. Now, very important is in a biopsy report of SLE, you'll always find an activity and a chronicity index. This gives us an idea of how active or how chronic is the pathology and whether we should treat it with immunosuppressants or not. Now, certain features of activity are presence of cellular crescent. So this entire thing, what you see is a glomeruli, and this part is actually the Bowman space, which is infiltrated by inflammatory cells forming a cellular crescent. So this is a strong marker of an activity. This pink thing, what you see here, these eosinophilic structures are your wire loop lesions seen in SLE, which shows significant subendothelial deposits. And over here, we can see something called as karyorrhexis, which is called as wherein there is a nuclear fragmentation that is seen, which is again a marker of activity. Now, what are the non-immunosuppressive therapy you can use in lupus nephritis? All patients of SLE should be initiated on HCQ unless contraindicated. Why? Because it improves the one-year renal response, it reduces the flare, it reduces the progression to kidney failure, and in pregnancy, it reduces the incidence of small for gestational age babies, and also it can reduce thromboembolic events in patients with EPLA. Now, what is the dose of HCQs? In induction phase, you start at 6.5 mg per kg per day, maximum 400 mg. Maintenance phase, you reduce it to 5 mg per kg per day. And if eGFR is less than 30, you reduce the dose by 25%. We all know the side effects are vision loss due to retinal toxicity. And this is more commonly seen in patients who are taking dose more than 400 mg per day or taking for a long period of time. Patients with underlying retinal disease, elderly patients, and patients with kidney or liver disease, because HCQ is metabolized by both the liver as well as the kidney. Now, always it's required to do a baseline as well as an annual ophthalmic evaluation. Now, RAAS blockers, that is either ACE inhibitors or angiotensin receptor blockers, they reduce proteinuria. And the ELNT trial showed that the most important predictor of long-term renal survival is the 1-year proteinuria less than 800 mg per day. Now, how do you assess response to therapy? You're given therapy, how do you know whether the patient is responding or not? So we have some parameters called as complete response, partial response, and no response. Complete response means proteinuria is less than 500 mg per day and creatinine almost returns to normal. Partial response is when you have 50% reduction in proteinuria, but it's still more than 500 mg per day and creatinine is within 15% of baseline. And if you don't attain complete or partial response, called as no response. Now, what is the correlation? Now, the 10-year renal survival, okay, is 10-year renal survival is significantly higher if you have a complete response. The relapse rates are lesser in a complete response, and the time to a relapse is also longer if you attain a complete response. Now, microhematuria is not included in the response criteria. The reason is 80% of patients have microhematuria. Microhematuria can be seen even in benign lesions like class 2 lupus nephritis, that is mesenteric proliferative lupus nephritis. And microhematuria is a little operator dependent, depends on the adequacy of your centrifugation that is done. Now, coming to the induction therapy in proliferative lupus nephritis. Now, steroid is the main agent that you start with. Now, IV methylprednisolone pulse should be given to all patients who have a RPGN or severe extrarenal disease, and then it should be followed by an oral prednisolone, which should be slowly tapered to the lowest possible dose by 6 months. Always remember there are a lot of side effects with steroids, and there are no patients of lupus who haven't experienced at least one of these side effects. So you have to keep a watch for the side effects. So PCP prophylaxis with cotrimoxazole. We also give antihelminthics in the form of ivermectin 12 mg for 2 days and albendazole a single dose. Proton pump inhibitor for anti-ulcer prophylaxis. Osteoporosis prevention with calcium and vitamin D supplementation, and always follow up with annual DEXA scans. If the DEXAs show osteoporosis, if the creatinine is, if the renal function is GFR is more than 30, it's better to add bisphosphonates. Now, annual ophthalmology checkup. One is to look for retinal toxicity to HCQs, as well as side effects of corticosteroids, that is posterior subcapsular cataract, glaucoma, and very rarely you may end up with central serous retinopathy. And monitor BP and sugars at a regular interval. What are the options for the second line agent? So one is IV cyclophosphamide, oral cyclophosphamide, or you can use an oral MMF. Now, IV cyclophosphamide can be given by 2 regimens. One is an NIH regimen and second is an ELNT regimen. So in NIH regimen, you give 0.75 to 1 gram per meter square monthly for 6 months. In an ELNT regimen, you give a fixed dose of 500 mg every 2 weekly for 3 months. Now, in the NIH regimen, every 14th day of the infusion, you do a total count and a differential count. If your total count is more than 4,000 and your absolute neutrophil count is more than 1,500, you increase it by 0.25 gram per meter square. If it is less than these values, then you decrease the dose by 0.25 gram per meter square. Now, oral MMF is given in the form of 2 to 3 grams per day. So what you can do is you start at 500 mg per day for 1 week, increase it to 1 gram per day for the second week, and slowly increase it to 1.5 grams per day up to maximum 1.5 gram per day. That is 3 gram per day by the 3rd or 4th week. But how we do it is we give a fixed dose of weight-based dose of 30 mg per kg per day, and we follow up with a MPA area under the curve values. Now, mycophenolate sodium is another option of mycophenolate, wherein 180 mg of mycophenolate sodium is equivalent to 250 mg of oral MMF. Now, there are some other emerging induction therapy wherein you can use rituximab or a multi-target regimen, which involves oral MMF along with a calcineurin inhibitor, that is tacrolimus or cyclosporin. Now, always remember to renal dose modify. This is many a times forgotten. Now, in the NIH regimen, if GFR is less than 30, the initial dose will be 0.5 gram per meter square. The ELNT regimen requires no dose modification, but the oral cyclophosphamide needs to be dose modified as per eGFR. Now, cyclophosphamide, important side effects are leukopenia, infections, hemorrhagic cystitis, and gonadal toxicity. Most of these side effects depend on the cumulative cyclophosphamide dose. MMF, the most common side effects are leukopenia, diarrhea, and teratogenicity. Now, hemorrhagic cystitis is commonly seen in oncological patients, but in rheumatological and nephrological patients with lower dose of cyclophosphamide, incidence is only 1.6%, and the incidence is found to be similar with or without MESNA. So for prevention, the best way of prevention is to give IV fluids prior to the infusion. Becomes a little tricky in patients who have severe renal failure or congestive heart failure. Now we have these three agents. We have an oral, we have an IV oral cyclophosphamide versus MMF. Now, what should be the most preferred agent? So, if you compare the NIH versus the ELNT regimen, what we found is similar outcomes at 1 and 10 years. And if you look at the cumulative cyclophosphamide dose in the NIH regimen is far higher than the ELNT regimen. So, if you have to choose between these two, ELNT would be safer with almost equal efficacy. Now, what about MMF versus cyclophosphamide? There was an ARMS trial which showed similar remission rates and adverse effects at 1 and 5 years between MMF and cyclophosphamide. Whereas study by Ginsler et al. Published in NEJM showed that the CR rates were higher with MMF and serious infections were more with IV cyclophosphamide. A meta-analysis of 880 patients showed again similar rates of ESKD and mortality between the two groups. So, what should be the therapy of choice? Now, the ELNT regimen of cyclophosphamide should be preferred in patients who have an RPGN and females with a completed family. Okay, whereas MMF should be preferred in patients with a preserved eGFR and young females who plan or wish to become pregnant. Now, coming to the maintenance therapy in proliferative lupus nephritis, we have two options here. Either we have mycophenolate or azathioprine. So, what is the data regarding this? So there was a maintained nephritis trial which compared between MMF and azathioprine as maintenance therapy, and they found that at 2 years, the protocol biopsy showed no difference. 3 years, relapse rates were similar, and at 10 years, the time to renal flare or ESKD or mortality was similar. But the ARMS maintenance trial, which included it was a multi-ethnic trial with 33% Asians in this, it showed higher treatment failure rates with azathioprine. Whereas a meta-analysis of the major trials showed, although ESKD and infection rates are similar, relapse rates are more with azathioprine. Therefore, the preferred agent, like in our case also, is MMF. When do we think of azathioprine? If a future pregnancy is anticipated, because MMF is teratogenic, if there is financial constraints, or if there is intolerance to the GI side effects of MMF. Now, what is the dose of MMF? Dose of MMF for induction, we said it's 2 to 3 grams, and for maintenance, we bring it down to 1 to 2 grams. But what we do, we follow the AUC and keep it around 30 to 40. Azathioprine dose is 1.5 to 2 mg per kg per day, but ideally it requires testing for TMPT, which is not done in most centers. So what you can do is start at a low dose, 50 mg, and slowly titrate the dose. Very important clinical point is to avoid xanthine oxidase inhibitors, that is allopurinol or febuxostat, when you're using azathioprine for hyperuricemia. Now, the reason because these xanthine oxidase inhibitors inhibit the metabolism of products of azathioprine, and there's accumulation of 6-mercaptopurine, and you can get very severe blood dyscrasias. How long should we give the maintenance therapy? Now, if the complete remission is attained, then you should at least give it for 18 months after attaining complete remission. So like in our case, 2 years down the line of attaining complete remission, patient was given mycophenolate. But if only partial remission is attained, it is better to give an indefinite therapy or rebiopsy prior to withdrawal of immunosuppression. Now, how do you treat resistant lupus nephritis? Before labeling a patient as resistant lupus nephritis, at least you should give a time period of 6 months for the therapy to act. Now, always rule out non-adherence. It's very common in SLE, and look for adequacy of dosing. This can be done by the therapeutic drug monitoring. That is what we follow at our institute. Now, in this paper by Susina Alexander et al., HCQ levels were studied in 171 patients of class 3, 4, and 5 lupus nephritis. And what they found was renal flare at follow-up, patients with renal flare at follow-up had a lower HCQ levels. And the minimum target HCQ level that is required to prevent a renal flare was 0.6 milligram per liter. Hence, HCQ level in this paper, they say, can be used to identify non-adherent patients. Now, in this paper by Susina Alexander et al. At our center, 34 lupus nephritis patients were prospectively initiated on MMF with a target MPA area under the curve of 30 to 60. Now, 60% of the patients had a MPA level below the target at that empirical starting dose of 30 mg per kg. Now, the median dose of MMF in the induction phase was 1.5 grams at entry, and it became around 2 grams after dose modification. Patients with albumin more than 3.5 had a greater chance of achieving area under the curve within the therapeutic range. Now, the 1-year renal response was found to be 79% with median time to renal response of around 111 days. And patients who attained an AUC more than 30 had a greater chance of attaining a renal response. And with this way of management, infections and toxicities were significantly lower. So, after looking for adequacy, if the treatment is adequate, the next step to do is to switch therapy. Like if the patient has been given cyclophosphamide, try MMF, like what we tried in our case. If it doesn't work, then the next step would be to give a multi-target therapy with MMF or CNI. But CNIs cannot be used if EGFR is less than 30 or if there is significant chronicity on biopsy, or to give rituximab. So studies have shown that in resistant lupus nephritis, rituximab has almost a complete response rate of almost 46%. Now, coming to how do you approach TMA in a case of SLE? The 3 main DDs you have to think about. One is a acquired TTP, second is an Epla syndrome, and third is an atypical HS. So for acquired TTP, you have to send an Adams 13 activity and calculate a plasmic score. If the plasmic score is more than 5, there is a high chance of this condition being TTP. And the treatment is steroid with plasmapheresis with rituximab. And there's a newer molecule that is caplacizumab, which is a monoclonal antibody against von Willebrand factor. For Epla syndrome, we have to send the entire panel of Epla workup. And the treatment for a catastrophic Epla is an anticoagulation with steroid and plasmapheresis. Rarely, some patients with atypical HUS due to antibodies or genetic mutations of complement pathway can develop atypical HUS, wherein the treatment of choice is eculizumab with a high response rate, or else other option is to give plasmapheresis with FFP replacement with a response rate of 40%. Now, when do we use immunosuppressants in membranous or class 5 lupus nephritis? One, if there is nephrotic range proteinuria. Second, if there is a renal dysfunction, or there is a persistent proteinuria more than 1 gram in spite of use of adequate RAAS blockade. Or if you have a combined class 5 with a proliferative lupus nephritis. And you can use a variety of options wherein you can use MMF, cyclophosphamide, CNIs, azathioprine, or rituximab. Coming to lupus nephritis and pregnancy, what are the prerequisites before planning pregnancy in lupus nephritis? So patients should be disease quiescent for at least 6 months. And you have to convert to a pregnancy safe regimen for at least 3 months before conception. So what are the pregnancy safe regimens? So drugs safe in pregnancy are HCQs, corticosteroids, azathioprinnes, and CNIs. Whereas drugs which are contraindicated are cyclophosphamide, MMF, and rituximab. In spite of all this, what we need to explain to our patients is there is a risk of 30% preterm deliveries, chance of flare of 20% during the pregnancy, preeclampsia 10%, and 8% chance of fetal loss. Now, although corticosteroid is said to be safe, it can cause maternal infections during pregnancy and gestational diabetes mellitus. It can suppress the fetal adrenal axis and in first trimester can cause cleft palate. Cyclophosphamide is contraindicated in the first trimester as it can cause a series of lesions called as cyclophosphamide embryopathy. In the second and third trimester, in life-threatening situations, you can use cyclophosphamide. MMF is contraindicated because it can cause craniofacial malformation in the form of absent pinna, external auditory canal atrasias, cleft palate, and cardiovascular malformation involving the aortic arch. RAAS blockers in the first half can cause cardiac anomalies, and in the second half of pregnancy can cause fetal renal anomalies. If you're using rituximab, you should avoid conception for at least 1 year. Now, lastly, coming to the RRT options in lupus nephritis, outcomes are similar in both hemodialysis as well as peritoneal dialysis. Patients on hemodialysis with Epla syndrome, there is increased incidence of dialysis access thrombosis. However, the best modality of therapy is kidney transplant. Like in our patient, kidney transplant, patient is being planned for a kidney transplant. Now, when do we plan a transplant? The old concept was wait for 6 months on dialysis till disease become quiescent. But the new concept is the outcomes are better if you do a preemptive transplant once the serological activity normalizes. What is the chance of recurrence post-transplant? It's around 4 to 11%. Mostly it's a benign class 2 lesion and it is not associated with graft loss. Now we'll go to a few case scenarios, interesting case scenarios. Now we had a patient of SLE referred from rheumatology with a 3-month history of anasarca, normal renal function, nephrotic range proteinuria with hypoalbuminemia and serologically active and normotensive. So we went ahead with a renal biopsy. What we saw was the renal biopsy showed normal glomeruli. There was no abnormality at all. So when you have a nephrotic syndrome in SLE, the most common etiology is classified lupus nephritis, that is membranous nephropathy. But there is an entity called as lupus podocytopathy. It's very low incidence, 1 to 2%. This behaves just like a minimal change disease, which you see in children. Now here you get a normal glomeruli on light microscopy. IF will not show any deposits. And on electron microscopy, you get a podocyte effacement. And the treatment is similar to how you treat an MCD, wherein you give steroids. Now, this is a 28-year-old female, known case of SLE. She's on treatment with HCQs, no prior kidney involvement, came with a rapidly progressive renal failure. Creatinine was 4.5, but urine routine was bland. 24 urine protein didn't show proteinuria. Albumin was normal. Serologically, she was active. Epla was negative. She had hypokalemia with low bicarbonates. We did an ABG which showed a normal anion gap metabolic acidosis. What is going to be the next step? The next step, we did a renal biopsy. And to our surprise, what we found was again a normal glomeruli, and the interstitium showed a dense tubulointerstitial infiltration. So when you have an RPRF with a bland urine in SLE, there are two possibilities. Most commonly, what you get is an Epla nephropathy due to Epla syndrome, or it can be an entity called as isolated tubulointerstitial nephritis in SLE. So in this entity, you have a raised creatinine presentation, hypertension, rapid progression to ESKD, and this is associated with type 1 or type 4 renal tubular acidosis due to antibodies against acid-secreting intercalated cells. Zebra bodies. Now, what are zebra bodies? This is a finding on electron microscopy, wherein you get what you can see over here, alternating zebra body-like structures, and you get something called as myelin whorls. Now, this is a finding which is seen in Fabry's disease, which is a lysosomal storage disorder due to deficiency of an enzyme in the lysosome. Here, something accumulates called as GB3, accumulates within the within various organs, and this produces this zebra bodies. But this is a biopsy of a patient of an SLE where an EM showed these zebra bodies. What is the association? So this is because of HCQ toxicity. So HCQ, long-term HCQ toxicity can, besides involving the eye, it can also cause something called as pseudo Fabry's disease, wherein you can get such deposits, zebra bodies within the biopsy sample. On conclusion, almost half of patients of SLE will have lupus nephritis on follow-up. Renal biopsy is a cornerstone for diagnosis and classification of lupus nephritis. Induction therapy involves either IV cyclophosphamide or oral MMF. Maintenance therapy options are preferred MMF or azathioprine, and options for resistant lupus nephritis include rituximab or multi-target therapy with MMF and CNIs. There are emerging newer treatment options. One is belimumab. Belimumab is a anti-BAFF agents. BAFF is a factor required for B cell proliferation. And voclosporin. Voclosporin is a modified cyclosporin. Thank you.